Good evening and welcome to my YouTube channel Pain Free Partha. Today's talk is about myofascial pain syndrome. Certain points which I tell may be from evidence and certain points may be from my own experience, and evidence may not be there. I'm trying to create evidence in certain aspects of myofascial pain syndromes. This is a non-inflammatory disorder of musculoskeletal region. There is no myositis. There is no inflammation. It's a non-inflammatory, but there is pain, but there is muscle stiffness. There are, along the fiber length, there are some irritable palpable nodules. They are called trigger points. So there is a pain, there is a muscle stiffness, and it is a non-inflammatory muscle problem, and they are associated with some bands, some palpable painful nodules. These are called trigger points. Now it started from 1850s, but what as a myofascial pain syndrome was described by Travel and Simons. They were the pioneers in describing it and including in IASP as myofascial pain syndromes. What do they come with? Already we have told it's a pain, regional pain, limited mobility, weakness, and there may be referred pain. And it is a chronic disorder. I have seen so many cases. They come with only 5 days pain and all. If you go into the history, they will tell these 5 days pain occurred last month also, 3 months also, 1 year before also. So we should go into the history of, because there may be a lot of triggering factors. What was the problem like? So that is very important in myofascial pain syndromes. See, what is the prevalence? Why we are bothered about this? Because it should be given more importance. That is what I feel. 30 to 90% have musculoskeletal pain. Patients has got musculoskeletal pain. 30 to 90% of these patients will have myofascial pain syndromes. Why is so large? Because no one knows which case has to be included in MPS, which case has to be excluded. But I would put it as 90% for my criteria. Disorder can affect any skeletal muscle. It doesn't mean that it has to come to orthopedics only. It may be general medicine. It may be orthopedics. It may be even gynecologist. So many people. Yes, 90% of the patients with pain management clinic, they have some form of myofascial pain syndromes. What are the examination findings? If you just tender spot in an affected muscle, there is a pain of region of reference. It is not dermatomal. That is a referred pain, but it is not dermatomal. You reproduce it. Again, if you do this, the pain will be there. Eliciting local tenderness and a taut band and documenting the local twitch response. There may be some weakness which are rare. What I want to say is there is an influencing factor which we'll discuss later. And this is a chronic pain. Go into the history. Followed by a muscle band. If you trigger it, there will be pain which may be referred, and there may be decreased movement, and this palpatory of taut band is very important. Now you see, these are all common trigger points in my practice. This is the common trapezius muscle. Okay, now this is the brachioradialis, and this is the suboccipital. Now we need to inject exactly. I usually inject without any sterilization are not needed. Just wash it and prep the things. There are so many muscles. Low backache, semitendinosus is an important trigger point. Gluteus, cervical, lumbar, paraspinous. What is active and what is latent? Trigger points may be active, but there may be latent also. Latent, what is the difference is there is no spontaneous pain. Only if you do this, there will be pain. Patient will not be having pain. That is what is called a latent trigger point. Now, the importance of eliciting a twitch, because just like that, if you do, you will end up in false negative. Now, this is
The
how we
trigger
should
point
do.
should not be pressed like this. No sound will produce. If you want the trigger point, know the trigger point where is it. Just do like this. You should do like this so that only the trigger point can be identified. Okay.
There are a lot of diseases. See, people will come with migraine, but there may be trigger points. People come with sacroiliac arthritis, clear-cut case, but they have also things. There may be periarthritis. There are a lot of vitamin and iron deficiencies. Post-thoracotomy pain, post-therapeutic neuralgias, or may be associated with, or many times associated with trigger points and myofascial pains. Trigger points can also, first what it say, active, latent. Latent means there is no spontaneous pain from the patient. Trigger points can also be classified into key and satellite. An active key trigger point in one muscle can induce an active satellite trigger point in another muscle. If you do the trigger point of the key tap, then the satellite trigger point without treatment will go off. So these are major trigger points you can see here, and there may be minor here. There may be latent here. So this is an important thing. There may be latent here. So these are the some of the points, trigger points, which are described. Now, what is the etiopathogenesis? There is some trauma which starts the trigger. It causes a thought band. This is latent. Now, if you put a stress here, then it becomes active. If you have perpetuating factors, it becomes active. So, and this active may cause more additional trigger points. But it can also progress without progression, it can persist, or it can go into spontaneous recovery. But here you see trauma, stress, influencing factors. These are the three things which makes a latent trigger point to be an active trigger point. Is there an electrical disturbance in the muscle? Have you done a muscle biopsy? Is there a lot of endogenous opioids? All these things have been described and thought of like people say that it is hypoechoic trigger point. But what I feel is here in the muscle there is some point which makes slightly hyperechoic. That is what is the trigger point. Now we have done a lot of study analgesic efficacy of ultrasound identified trigger point injections. This is very important. Even though there are other features, if you could identify with ultrasound, that is better. Now, if you see trigger points and
ரொம்ப வலிக்குது. சரி. ஓகே. இப்போ பாருங்க. லேசா இருக்கு. இங்கே வித்தியாசம் இருக்கா?
now you can see in the film picture video, the above point was an active point or a key point, and the second one is a satellite point, key point and satellite point, which we identify. What is the biochemistry of trigger points? Prolonged and irregular contractions. There are some chemicals, some ischemia. They sensitize the nociceptors, local pain. And there is a persistent trigger, and there are spinal cord changes. We have already told this is about biochemistry. What is the pathophysiology? Stress and influencing factors. That's what I told. Perpetuating factors. Sometimes we see the upper limb is not to be used as a pillow. Pillow is pillow. Sometimes you use a mobile phone like this, you get some perpetuating factor of myofascial pains. I have seen one person who developed severe myofascial pain here because what he did was because of the vastu in his business place, he changed the cash box in the back. sleep without pillows, bad posture in watching TVs. All these are biomechanical or influencing factors or perpetuating factors in myofascial pain. So this is our article, assessment of predisposing factors. Management of myofascial pain syndrome is inactivation of these active trigger points, restoration of muscle length, the elimination of correction of factors. We know that this was that. The cell phone was like this. So you have to eliminate like this. Use the trigger point injection. Open up the muscle and avoid your perpetuating factors. Trigger points is massage treatment is there, release technique is there, spray and whatever it is, spray and diclofenac or whatever it is, and stretch. So many techniques are there, but what I feel is injections are always better. Now you can see, I don't
சொல்லும்போது
use
இப்போ
a lot of gloves.
எங்க
I just
ஷாக் அடிக்குதா?
do like this and elicit the shock. As soon as you prick,
வலிக்குது.
that will be there.
சரி, இப்போ
Then
ரொம்ப வலிக்குது. இப்போ ஷாக் அடிக்குதா இருக்கா? சரி, நல்ல சத்தமா சொல்லுங்க, ஷாக் அடிக்கிற மாதிரி இருக்குல்ல? சரி, ஓகே.
that is what is a success. Repeat probing of the top bank useful in targeting satellite points. Sometimes increased pain, yes, very important. Sometimes a trigger point may cause some problem in this, and pain may be there extra for 2 hours, followed by a relief for 15-20 days. Maybe spasm of the antagonist muscle. There may be some bleeding. Otherwise, very minimal complications of trigger point injections. I have used thousands, so infection doesn't occur at all. Dry needling, local anesthetic, steroids, and botulinum. But I use both because, see, the thing is, you prick them with the needle. That is very important, needling, and you elicit that response. Then sometimes muscle pain will be very painful. So you need add some steroids to open up the stretch of the muscle. And then if you add lignocaine, it will be painless, but lignocaine can cause some sort of myofibrosis. So add steroids. So this is my point of minimal steroids with minimal lignocaine. A lot of patients complain of pain if you use needling or steroids alone. Hence, lignocaine is added. But lignocaine is not good for muscles. Treatment is actually needling and getting the taut band released. Needling is ideal. There are other modalities: TENS, high voltage galvanic, interferential therapy, frequency modulated electro, so many things, ultrasound, laser, magnet therapies. Whatever it is, you have to release the taut band. TENS and acute, they work by gate control theory. Yes, we can use this. Drugs like paracetamol, weak opioids, sertraline, usually patients come to us after taking all these things only. So they will be on these drugs. So unless you release the trigger point, this is not going to be much effect. Correct the perpetuating factor. Sometimes it will be there effective for 15-20 days. Sometimes you need to repeat the injection. So I sometimes do one and then after 15-20 days and then again after 15-20 days. Mostly if you correct the perpetuating factor, the pain relief is excellent and it may be decreased even by 75 to 80%. Long term is reported in 70% of the injuries. What is fibromyalgia syndrome? It's widespread pain. But there are no taut bands. Even in myalgia, fibromyalgia, FMS, there may be some, they call it as fibrocytic trigger points. But there are no taut bands. That's what I told in that violin. They have more psychosomatic and behavioral changes. Now you can see female is more myofascial, male is more. Local pain, referred pain. Widespread, somewhat regional. Tender point anatomy is muscle tendon junction. It is usually in the muscle belly. So fatigue, drugs, prognosis is difficult for this, but in MPS it is easy. So we know the definition: etiopathogenesis, a taut band, followed latent, followed by stress and influencing factors like this. There are so many influencing factors like this. What is the prevalence? I'll say put up as 90% for patient coming to pain clinics. Associated diseases like periarthritis may have a trigger point and myofascial pain. Osteoarthritis, knee will have some sort of myofascial trigger points. Trigger point injection is very important. You should see the jump response. That is very important. Jump sign is very classical of myofascial pain syndrome. And you elicit the jump pain and put that needle there. You have, unless you do that, your efficacy of treatment will be less. Look for perpetuating factors, cell phones, pillows, TV like that, your mobile phones, your laptops. All these things have to be properly, ergonomics should be proper. A lot of non-pharma treatments, drugs have been used. What I use mostly is after the injection, I use a local diclofenac gel and flupertine in the night, which is an NMD antagonist. Thank you very much. Thank you.